can see how the bone ends could easily slide over each other, making it very difficult to keep such fractures in a stable position. Now consider this fracture. How stable is it? It demonstrates some comminution and has a butterfly fragment. Fractures like this may not only be longitudinally unstable, but may also be unstable to angulation. Soft tissues are important to fractures, and not just in terms of achieving and maintaining reduction. They also act as a barrier to infection and provide blood supply to the healing fracture. Damage to the soft tissues is therefore important in determining the prognosis of fractures. To highlight the importance of the soft tissues, it's worth remembering the Gustelow classification of open or compound fractures. This classification grades compound fractures based on the length of the wound. Thus, a grade 1 compound fracture has a wound less than 1 centimetre long. These fractures are usually, but not always, compound, from within out. A grade 2 fracture has a somewhat longer wound of between 1 and 10 centimetres and can be compound from either without in or within out. A grade 3 compound fracture is any fracture where there is a wound greater than 10 centimetres. Such fractures are further subclassified depending on the degree of soft tissue stripping and whether or not there is any neurovascular damage. Although less widely used, Tsern and Gottson also graded the severity of soft tissue injury in closed fractures. Grade 0 is where there is little or no soft tissue damage. Grade 1 injuries have moderate bruising or swelling or a superficial abrasion. Grade 2 injuries have a deep abrasion or tense swelling and bruising. Whilst in the most severe grade 3 injuries there is associated compartment syndrome or neurovascular injury. Let's now consider how to immobilize fractures, the I part of our mnemonic RIP. The first question you should ask is, do all fractures require immobilization? And the answer is no. Some may have sufficient intrinsic stability due to the local soft tissue arrangements or be so impacted in cancellous bone that they do not require immobilization to maintain patient comfort or for the union of the fracture. But if a fracture does require immobilization to maintain a good position, what can you do? One of the simplest things you can do is the application of a cast or splint. This is an example of the sort of cast you could apply for a simple ankle fracture. Many long bones have an effective soft tissue sleeve, such as in the humerus or in the femur, which are completely surrounded by muscle and fascia. If you apply longitudinal traction onto the limb, you will tighten this sleeve, and this will frequently give a good reduction as well as self-splinting the fracture. Here is an example of skeletal traction within a Thomas splint, the sort of thing that was commonly seen in orthopedic wards a number of years ago. Not all fractures can be successfully treated by these methods. Therefore, you should think about what internal fixation may have to offer. Here's an example of internal fixation that has been used to stabilize an intra-articular fracture in a weight-bearing joint. Finally, there is external fixation, and here we see an example of a rather poorly healing compound wound that has been treated using an external fixator. Now let's consider the last part of our mnemonic, the P of RIP. It may be the last, but it is by no means the least. In fact, it's probably the most important aspect of fracture management. Movement is something you should consider from the very outset of treatment, because it is the restoration of movement and function that is the goal of all fracture treatment. The responsibility for achieving the restoration of movement should not simply be handed over to the physiotherapist. In fact, physiotherapy is not always required, as many patients will manage to mobilize well on their own after some instruction on how to exercise the limb. All patients should be encouraged to move their injured part actively as soon as this is appropriate. In the next exercise, you will be applying a full forearm plaster. This should allow full movement of the elbow, thumb and fingers, as early movement of these joints will significantly improve the outcome. So, we have reviewed fracture management, considered the clinical signs of a fracture, the imaging of simple fractures, and discussed a simple mnemonic for the principles of fracture treatment: reduction, immobilization, and physiotherapy. RIP. So, now on to the practical exercise of applying a plaster cast. Plaster bandage is widely used for the splintage of fractures and immobilization of joints and limbs to protect them whilst healing. The principles of plastering will be demonstrated by performing a back slab onto the forearm. Firstly, stockinette is prepared with a hole to permit the thumb to pass through and should extend distally up to the metacarpal phalangeal joints and proximally up to the elbow. Assuming the treatment is for a Colles type extension injury, there should be minimal ulnar deviation and approximately 10 degrees of palmar flexion. Apply a soft roll, which should not be more than 4 inches in width, and run from the metacarpal heads, covering with a 50% overlap, passing up the forearm. Avoid bunching, particularly around the thumb, which is often more easily dealt with by making a hole in the soft roll. Ensure that there are no lumps and a consistent thickness of material. Use 6 layers of plaster bandage. The slab should be an appropriate width and length. Frequently, people use a narrow slab, often out of nervousness, and this just lies on the forearm rather than gripping it and controlling the bones. Cut a well for the thumb and make sure it is smooth so that there are no irregular areas to be cut later. Fold the plaster and then dip it into cold water, retaining the 2 ends in your hand until all the bubbling has ceased. Remove the plaster bandage, wring it out lightly, and then spread it out over the forearm, matching the prepared cuts for the thumb and the metacarpal heads. Stretch it on longitudinally and pass the volar component carefully and smoothly under the flexor tendon region at the wrist. Now retain the plaster on the forearm by using a cling bandage, which may be pre-dipped in water, and make sure that the bandage is applied smoothly. Pass carefully around the thumb and apply with even tension. When the end of the bandage has been reached, this should be fixed in place with a small piece of adhesive tape, although some surgeons would use a small strip of plaster. There is a danger that if the plaster strip goes all the way round, that it may defeat the object of a back slab. Ensure that the degree of ulnar deviation and flexion are correct. Ensure that the plaster is smooth and is of the right length. It should allow adequate flexion at the elbow with no irregularity of the plaster. Be sure the knuckles are clear and that the plaster is smooth with adequate padding. Also, that there is softness around the thumb, allowing for mobility. there should be an area on the anterior surface free from plaster to allow for any swelling to take place. The patient should also be able to make a fist without any difficulty and without the plaster cutting into it. Don't forget to ensure that thumb movement is adequate as well. Before applying the plaster, ensure that all the equipment is gathered together. If a decision is made to use stockinette, ensure that there is no likelihood of swelling, as the limited stretch of stockinette can easily cause constriction. Cut the stockinette as appropriate, making a hole for the thumb and then gently roll it onto the limb. It is important to position the limb before you apply further padding. The position will depend upon the injury, but in this case we're going to place the wrist in a slightly palmar flexion and ulnar deviation. It may be necessary to apply padding to the bony areas, such as the ulnar styloid, as you see demonstrated. Once you're happy with the position, apply a layer of padding, smoothly covering half the previous turn, and making a hole as appropriate for the thumb. Two layers should be applied around the base of the thumb, positioning the hole carefully each time. When it comes to breaking the padding, hold the wrist firmly so the patient does not suffer discomfort or movement of the fracture site. Hold the plaster bandage loosely in the palm of the hand with the first few centimeters unwound to make it easier to find the end. Then soak the bandage in a bucket of lukewarm water, submerging it at an angle of about 45 degrees, and count 3 to 4 seconds. Then remove it and gently squeeze the excess water out of the bandage. Start bandaging at the elbow end of the cast, winding the bandage round the limb, roll side uppermost. Do so evenly and without tension, overlapping each turn by 1/3 of the width of the bandage, allowing a tuck as necessary. The bandage should be gathered gently as it goes around the grip, and should not be pulled too tightly round the metacarpal heads. A second bandage is then applied quickly before the first bandage has set. 3 turns through the grip in total should be adequate. Constant smoothing and moulding is required to produce a satisfactory plaster. If stockinette has been used, this can be turned back over the edge of the plaster, and then a further plaster strip about 10 centimeters wide and folded in half can then be used to fix this in position. It is important when applying this strip of plaster to ensure that this does not go over the edge of the stockinette, thereby creating a sharp edge. For the plaster strip around the grip, shape this as shown here. Once this has been dipped in water, apply it carefully around the grip and the base of the thumb, again ensuring that it does not go over the edge of the stockinette, and that it is adequately smoothed down. At all times, it is essential to mould the plaster to ensure that there are no sharp edges. A similar strip can be prepared and placed around the base of the thumb to ensure a smooth and firm fitting, while still allowing full mobility of the thumb. Once completed, ensure that the plaster is even. It is vital to give the patient verbal and written instructions on the care of the plaster and the prevention of possible complications. Make sure the patient really understands the situations in which they should return urgently to hospital. The plaster should allow the palmar crease to be free, ensuring full flexion of the fingers. The metacarpal heads should be just outside the plaster as well. Full mobility of the thumb and the elbow is essential. There should be at least 2 fingers breadth between the crease of the elbow and the edge of the plaster. When a cast needs to be split to relieve circulatory or nerve impairment, a single longitudinal cut is required for a full plaster of Paris cast. If the cast is to be bivalved, then this will require a mark down the medial and lateral aspect of the cast, avoiding any bony prominences. Once the cast has been adequately marked, it should be divided with plaster shears, or, if the cast is dry, an electrical oscillating saw. When using shears, keep the blade parallel with the limb. If the blade is tilted either way, it will dig in or nip the patient. The hand nearest to the cast holds the blade parallel and remains still. To cut the cast, push the shears together with the other hand and then proceed down the cast, cutting it as clearly demonstrated here. If the shears are removed and reinserted, take care not to nip the patient. Proceed until the entire plaster is divided. The saw uses an oscillating circular blade which rubs its way through hard plaster. It must be used on a dry padded cast, and the blade held at right angles to the cast and used with an in and out motion, as seen here. Having cut through with the oscillating saw, it is important to divide the stockinette and padding with plaster scissors to ensure complete division of the plaster. Ensure that there is adequate separation of the plaster edges to accommodate any edema. If necessary, this can be achieved with plaster spreaders. A little padding can then be placed in the defect and a bandage applied to keep the plaster and padding in place. Once again, care should be taken around the grip. Once the crepe has been applied adequately, this may then be taped in place. At the end of the exercise, feel the inside of the cast to ensure that there are no ridges or areas of pressure. Although both a full plaster and a back slab have been demonstrated in the video, only the full plaster technique will be used in the actual exercise. This will allow participants to gain experience in plaster removal as well. Laparoscopic surgery relies on complex equipment, consisting of TV monitors as seen here, which display the image showing the surgeon what he is doing. The image is supplied by a camera which is attached to a laparoscopic telescope that is inserted into the peritoneal cavity. The laparoscope is connected in the manner you see here, and then focusing can be undertaken on the instrument itself. Light is provided by a fibre optic cable, and as this is inserted into the light source, the fibres can be seen as the light travels down the cable. This is then connected to the laparoscope. The setting on the light source is usually on automatic to reduce flare and is set at the lowest level of illumination possible to achieve safe surgery, whilst at the same time giving adequate vision. The period of lamp life may be indicated on many of the light sources. The image provided can then be seen on the TV monitor. As light is a mixture of red, green and blue, a white balance may need to be set at the outset of the procedure to prevent the image from looking too blue or too red. An insufflator provides carbon dioxide for distension of the intra-abdominal cavity. This is provided by a cylinder, and the gas flow should be turned on. You should ensure that an adequate amount of gas remains in the cylinder to cover the whole procedure. The pressure should be set and the flow rate controlled. A safe technique for the introduction of trocars or ports is absolutely crucial to the performance of safe laparoscopic surgery. Lethal damage can easily be caused by clumsy port insertion, and it is essential that you familiarize yourself with the instruments before use. This is especially important when inserting the primary trocar. Make a mark on the simulator provided to represent the umbilicus. Then make an infraumbilical incision of approximately 1 to 2 centimeters. Deepen to a level representing the linea alba, which may be marked with a red felt tip pen, and then insert a stay suture on either side of the linea alba. Place the stay sutures in hemostats and place to one side. Once both stay sutures are in situ, incise the linea alba down through to the peritoneum, and then go through the peritoneum very gently and carefully until the abdominal cavity is entered. Use the stay sutures to hold open the hole, and a finger can be passed into the cavity to ensure that there are no adhesions under the surface of the abdominal wall. Several different types of port may be used for the open technique or Hassan insertion. Use a blunt trocar cannula and insert it into the peritoneal cavity and rotate it around to the correct angle. Use the stay sutures for positioning and fixation of the port, and put a hemostat on the end of the sutures.